Well, hello. My name's Trevor Duke and I'm a paediatrician. This lecture series is about the World Health Organization Pocketbook of Hospital Care for Children guidelines that were introduced in 2005. Now, the World Health Organization has a program called Hospital Care for Children. It's a series of evidence-based guidelines that, as I said, was first published in 2005 and the second edition was published in 2013. The third edition is in the pipeline. It's of use in district level hospitals, so hospitals of first referral level after primary care, usually. But it's also of use in secondary referral hospitals, and even it's relevant to tertiary hospitals. A study in 2013 showed that the book, The Hospital Care for Children, was used in at least 98 countries, including 30 countries with high infant and child mortality rates. The World Health Organization has a program of training, a 4 or 5 day training course that is designed to teach healthcare workers how to use the book in everyday clinical practice. The program has modules on all the chapters in the book, the chapters which include chapters on cough and difficult breathing, diarrhea, fever, surgical conditions, severe malnutrition, etc. There are modules on all of these chapters. In addition to the training modules to support the Pocketbook of Hospital Care for Children, the World Health Organization has released guidelines on mortality and morbidity auditing, on other aspects of quality improvement, including oxygen therapy for children guidelines. Now, today we're going to go through one module in this lecture series. The module is on Chapter 4, Cough and Difficult Breathing. The way the modules work are that they are case-based scenarios going through a case that can be used to where we demonstrate how the book is used to manage the patient and to teach you how to use the book in everyday clinical practice. I'm going to start sharing my slides and then we'll start. As I said, this is a module about Chapter 4 from the Hospital Care for Children book. This is, as I said, the second edition, which was published in 2013, and the course was first developed in the late 2000s and has been revised multiple times since then to keep it updated. This is the course based on the 2013 edition, but also updated since then. So cough and difficult breathing. As I said, it's case-based scenario. I want you to have a look at this young boy. This was a boy named Ratu. He was 11 months old and he presented with 5 days of cough and fever. And the day before, he became short of breath and was unable to feed. That's all you know when a child presents to an emergency department or a clinic. That's really all as much as you know. But you can know a lot more by observing the child for even a brief period of time at triage. And I'll go through in how this book describes the different stages of management of every sick child. And so we'll do this for this boy named Ratu. You'll have made some observations already about this child's degree of respiratory distress, their general condition, etc., in the very short period, less than 30 seconds that you've been able to see this child. So the World Health Organization Pocketbook of Hospital Care for Children describes the stages of management for any sick child. There are 10 stages of management, and these are all included in the book. And each of the chapters, each of the conditions goes through each of the stages in general terms and describes what is required at each stage. The first stage is triage, and we'll talk about that in more detail. The second stage is if you find any emergency signs, then give emergency treatment. The third stage is taking a history and doing a thorough clinical examination after the child's stable from the emergency treatment. Fourth, laboratory investigations if they're required and if they're available. Fifth, come up with the diagnosis, make a diagnosis, and decide on whether or not there are other diagnoses present. Many children have comorbidities, more than one diagnosis, and there's a need to identify all the possible diagnoses. Sixth, give treatment for the underlying and diagnosis and other comorbidities. Seven, provide supportive care, and that may include nutrition, fluids, fever management, more oxygen therapy, for example, other aspects of care that are not treating the main diagnosis but supporting organ systems. Eighth, monitoring, very important. Many children deteriorate even after they've had treatment in hospital, and these children need to be monitored to identify the deteriorating child. Ninth, discharge planning, and 10th, follow-up. These last two things, discharge planning and follow-up, are often not well done in many hospitals. The same with supportive care and monitoring. Many people are good at making a diagnosis and giving the treatment, but the other aspects, the other stages of management are often not well done. Many studies have shown this in the last 20 years, that unless you go through all of these stages, then there are many things that are missed out. So at triage, it's quite easy to learn how to do triage well. And within a minute or two, you can identify a critically ill child. How to quickly assess for emergency signs, where you take a brief history of the presenting problem. It's very important to have some understanding of the presenting problem. And that's what you knew from the introduction I gave you. Take the temperature of the child and weigh the child. It's important to weigh the child because any medications that you might need to give will be based on often based on the weight of the child. You should listen for stridor or obstructed breathing. So when you're assessing the child's airway, listen for a stridor or obstructed breathing. Look for cyanosis in terms of breathing, or B, look for cyanosis and any signs of respiratory distress. So check for chest indrawing or tracheal tug, and check the oxygen saturations if you have access to a pulse oximeter. In terms of circulation, you should feel the skin, temperature of the hands and the feet, feel the pulse for volume. So it's very important to get used to feeling a child's hands and feet, feeling their pulse volume at the radial pulse, or in the foot, the dorsalis pedis or the posterior tibial pulse. Check the capillary refill time. A child who has warm hands and feet, good pulse volume at the radial or the dorsalis pedis or the posterior tibial, and has a capillary refill time less than 2 or 3 seconds, they don't have shock. They don't have major circulatory impairment. And you can very quickly assess that. And then D for disability or conscious level, assess for lethargy and the level of interaction the child has, whether it's age appropriate or not, whether they seem more lethargic than normal, whether they're conscious or unconscious, etc. And you can do that using the alert, verbal, painful, unresponsive score, the AVPU score, whether the child's alert, whether they respond to you verbally in an age-appropriate way, whether they respond to painful stimuli, or whether they're totally unresponsive. There are other ways, other scores and scales you can use, of course, the Glasgow Coma scale and that sort of thing. But you very quickly at triage, you can do this within a minute. And it's important to practice doing triage because then it becomes second nature to you and you get very good at it. So triage is a very important stage in the management of any sick child. The question is, do you notice any priority signs in this child? And in the Hospital Care for Children book, you can look up what the priority, the emergency and the priority signs are. And already we've seen this short clip, and I'm sure you can see that Ratu has severe respiratory distress. He has tachypnea. He has intercostal recession. You can see that his chest sucks in between his ribs, and his chest seems to suck in below his sternum. He looks he does look alert. He's looking around, so he's alert. He scores highly for the D for disability. You can't appreciate that he's got any airway obstruction, but he's got severe respiratory distress. So going through it, his airway seems fine. His breathing is very impaired. We haven't assessed his circulation because that's based on feel and feeling his hands to see whether they're warm or cold, feeling his radial pulse or his dorsalis pedis or posterior tibial pulse, and checking his capillary return. So I had triage. His temperature was 39.7. Remember I said weigh the child and take the temperature. Feel the pulse. His pulse volume was very fast, but still his circulation seemed okay. He had warm hands and feet, perhaps because of his fever. He also had a strong pulse volume, but it's still very fast. His respiratory rate, if you count it, is about 70 per minute. He was cyanosed before going on to oxygen, and he had suprasternal, as you could see, and subcostal recession and grunting respiration. And his oxygen saturation when measured was only 77% in air. So if you refer to the Hospital Care for Children book and go to page 2 and page 6, you'll see the emergency signs and priority signs. I want you to focus on the emergency signs at this stage. That's the first thing you should look for. Does Ratu have obstructed breathing? It wasn't very obstructed, but he did have severe respiratory distress, and he did have cyanosis on air, and his oxygen saturation was low. So he does have severe hypoxemia. He had a fast heart rate, but his pulse was good volume and his capillary return was normal. So he doesn't have signs of shock. He wasn't in coma. He didn't appear to have convulsions, and he didn't show signs of severe dehydration. So Ratu has at least 2 emergency signs. Now, remember, you only have to find one emergency sign to then give that emergency treatment. So Ratu had severe respiratory distress and central cyanosis. That's enough to stop the assessment and give emergency treatment. And the emergency treatment is simply giving oxygen. And when you're giving oxygen, I'm sure you are aware there are several ways to do it, many ways to do it, but usually the most efficient way to give oxygen is using nasal prongs. And usually these days, binasal prongs are given. In the past, we often used to use a nasal catheter, which is a nasal oxygen catheter. It has a small hole in it. If you're using a nasal catheter, the measurement is between the tip of the nostril and the inner surface of the eyebrow, and that tells you how far to insert the nasal catheter. Measure the distance from the side of the nostril to the inner eyebrow margin with the catheter, and then insert the catheter to that depth, and then add some tape. Usually now binasal prongs are used, small binasal prongs, and the amount of oxygen that is required is somewhere between 0.5 litres per minute and 2 litres per minute. Most children, you'd start with such severe respiratory distress, you'd start at 1 to 2 litres per minute. In the book, there's a chart on how to give oxygen on page 11 if you need, and there's a more information about giving oxygen on page 312 and 315 in the second edition of the book. There's also, as I said, WHO has a clinical guideline on the use of oxygen in children, oxygen therapy in children, it's called, published in 2016. You should start the oxygen flow at about 1 to 2 litres per minute. In young infants and neonates, then 0.5 litres per minute is usually adequate. I want to show you the dramatic effect of oxygen, and this is another child. This is not Ratu, but this is another child, and I want to demonstrate how effective even relatively low flow oxygen can be. Just look at this child he's alert to start with, but then he becomes a bit drowsy, and you can see his oxygen saturation starts at around about 53, 52. In fact, it drifts even below 50 at one point in time. His saturation drifts below 50, and you can see that he's fallen asleep. He's become poorly conscious because of that. This is this same child within a minute he's now awake again, and his oxygen saturation is 98%. And this is what was done to fix his hypoxemia, simply giving him about 1 litre per minute via an oxygen concentrator. So it can have a very dramatic effect, giving oxygen in this way to a child, even with quite severe hypoxemia. This child had a saturation that was less than 50, and all he needed was to be promptly put on oxygen. So back to emergency treatment, there's some other things you would do at emergency in a child like this. You might check their blood sugar, and Ratu's blood sugar was 1.8 millimoles per litre. This requires a glucometer, of course, and that's not always available, but the question is how to treat hypoglycemia. We can see this in the book too. You can either give, obviously, glucose intravenously if you've got an IV line in, or you saw that Ratu had a nasogastric tube. You could give some glucose nasogastrically or sublingually. There is a chart on page 16 of the book, the second edition of the book, which describes how to give glucose appropriately to a child who's hypoglycemic. The next stage, as I said, after triage and emergency treatment, is taking a history and doing an examination. And so you've already taken a brief history, but we need to take a more extensive history if we're going to work out what's wrong with Ratu. Now, you know this or some things already. He was an 11-month-old boy with 5 days of cough and fever. And yesterday, just 1 day ago, he became short of breath and was unable to feed. He'd been well until 5 days ago. This is very important to find out from the parent or the caregiver just when was the child last well. We often don't ask that question, and sometimes we miss, therefore, that the child's been unwell for quite some period of time. They may only present because the child deteriorates, but the child might have been unwell for quite some time with a chronic illness, and then they've got an acute infection or illness on top of that, and they become more unwell. Well, from his parents, they say that Ratu was quite well until 5 days ago. Then he developed the fever with the cough. He was taken to a local pharmacy, a medical shop, where he was given 2 types of syrupy medicine. The parents didn't know what that was. He deteriorated after another 2 days with high fever and increased difficulty breathing. And today, when he was brought to the hospital, he couldn't feed. He'd had no significant past illness that the parents knew about, but he did have a family history that his grandmother had tuberculosis, but she was fully treated long before Ratu was born 3 years ago. Ratu lives with his parents and his grandmother in a 3-room house, and they have their own water supply from a tank. On examination, Ratu was pale and cyanosed, as you know. He had fast breathing and suprasternal and subcostal recession and grunting respiration. You saw all that in the video clip. His temperature we saw at triage was 39.7, his heart rate 180, and his respiratory rate was 70. His oxygen saturation was 77 in air, but when you examine him again after he's been put on oxygen, his saturation is now 93%. His weight was 8.2 when measured at triage, and you should check his weight for age on using the tables in the Hospital Care for Children book. There are tables of weight for age and growth charts that you can use in the book. Growth charts of children, the World Health Organization growth charts that show the expected growth for age. The child had, on examination of Ratu's chest, he had bilateral coarse crepitations with, again, that recession again and grunting and wheeze. So he had both crepitations widespread in both lung fields and wheeze. He had capillary refill of 2 seconds and a pulse volume which was normal, a strong pulse volume, and he had 3 heart sounds with the Gallop rhythm. So again, he's tachycardic, he's got a Gallop rhythm, which implies that his heart is working fast, and his liver was palpable 4 centimeters below the right costal margin. So already we're starting to think that Ratu might have some signs of heart failure. He's got tachycardia, he's got a big liver, he's got a Gallop rhythm. But he doesn't have shock. His capillary return is okay, and he was warm and well perfused. His liver was palpable, so it might be that he's got a congested liver. He was tired, but he looked alert. You saw the videos, and he had no neck stiffness. He had quite significant pallor of the palms. That can indicate severe anemia, almost always indicates severe anemia. And you can check the assessment of anemia on page 166 of the Hospital Care for Children book. You should check in 3 places. Check for palmar pallor, check conjunctival pallor, and pallor of the mucous membranes of the tongue and the gums. Any child with severe anemia or hemoglobin less than 6 or 7 will have pallor of all those areas. In any child with severe pallor, you should check the hemoglobin level if you can. So once you've done it, taken a history, done a full examination, then you need to have a bit more of an understanding of the possible diagnoses that are likely in this child. And this child had such severe respiratory distress, and he's got some signs of heart failure, and he's got severe pallor. Then you're starting to build up the diagnostic possibilities. So you should, I think at this point, you should think of the 3 likely causes of this child's illness in the order that they are most likely, and use the clinical features to say which are the most and the least likely. There's the book has tables of diagnoses that are relevant to common presentations, and from that it has the clinical features of that diagnosis, and you can use the book to these tables to try to decide which are the most likely diagnoses and which are the least likely. There on page 77 to 79 and page 93 of the book, of the second edition of the book. So which clinical features make these diagnoses more or less likely? You can check it up in the book. Which features that we've seen in Ratu make pneumonia more likely, for example? Well, his high fever and the crepitations make pneumonia quite likely. His degree of respiratory distress, of course. Ratu could have had malaria related to the high fever, and you need to maybe go back and find out whether the child came from a malarious area or not. Ratu was very pale, and so you might think that he's 11 months old. That's a typical time that infants become pale if they have nutritional inadequacy, for example. So you would go back and you would take a history from the mother, a more detailed history about his nutritional state, perhaps, and you check his hemoglobin. Ratu had signs of heart failure. He had tachycardia, a gallop rhythm, a big liver, a 4 centimeter palpable liver, and to get a bit closer to that diagnosis, you would want to do a chest X-ray if you can. He also had crepitations in his lungs, which can be a feature of both of pneumonia, and it can be a feature of heart failure, of course. And he also had wheeze. And in young infants who've got severe pulmonary congestion, then they too can have wheeze, not just with bronchiolitis or with asthma, but children with heart failure for whatever reason, for a severe anemia, or because they've got a ventricular septal defect or some form of congenital heart disease, they too can have crepitations and wheeze. And they can have that because they've got edema of the bronchial mucosa, and it narrows the bronchial mucosa, and then you get wheeze because of airflow obstruction. So the features of heart failure in this child include tachycardia, a gallop rhythm, a big liver, crepitations, and wheeze. We know that Ratu's grandmother had tuberculosis, but that was 3 years ago, and at least 2 years before he was born. So it makes it less likely, but it just means there is tuberculosis within the family. So one should always think of tuberculosis. Now, Ratu's history is that of being only unwell for 5 days. So it makes it less likely, but it's not impossible, because there are some children with tuberculosis who the family might not recognize that they've been unwell, or they actually present with an acute infection, with an acute pneumonia, and it turns out to be tuberculosis. So should not rule that out. Pertussis is another possible cause of severe respiratory distress. There are a number of others in the book, which I won't go through all today. Pertussis, a foreign body, seems unlikely in this case, but one should always think about it. An effusion or an empyema is certainly possible, and using either both clinical signs and a chest X-ray will help you diagnose that. If you had an ultrasound, you could also look to see if the child's got an empyema. There are many ways you can do that rather quickly. It is very important to identify an empyema, because if a child's got an empyema or an effusion and you only treat them for pneumonia, then their respiratory distress will not resolve. In fact, it'll just get worse because they've got pus in their pleural cavity, and it will be an undrained source of infection. Their toxicity, their infection will remain severe, and their respiratory distress will get much worse. A pneumothorax is possible in a child who becomes suddenly unwell and unable to feed after a few days of an illness. You can usually identify that by clinical signs, but also a chest X-ray will obviously help, and an ultrasound can help you identify a pneumothorax in a child as well. Then lastly, in the differential diagnosis in the hospital care for children book, it lists pneumocystis pneumonia, and pneumocystis, of course, is a special sort of pneumonia that really only occurs in children with immunodeficiency, whether HIV or some other immunodeficiency. And it's important to think about it in a child with severe respiratory distress and severe hypoxemia, only because it requires a different type of antibiotic treatment to other forms of pneumonia, and also it can alert you to the possibility of an immune deficiency in the child. Because the child, Ratu, was severely pale, you would want to go back and ask some other questions. Perhaps you'd ask questions about this child's immunization state. You'd want to know whether he was a well-immunized child, or whether he had no immunizations, or whether immunizations are largely up to date. Well, Ratu was 11 months old. He still hadn't had his 9-month vaccines, but all his other immunizations at birth, 2, 4, and 6, or 1, 2, and 3 months, were all up to date. But he missed out on his 9-month vaccines, which is his measles vaccine, of course. Worth thinking about. Because Ratu was very pale, you would want to take a nutritional history, a detailed nutritional history, And this is Ratu's nutritional history. He was breastfed for 3 months, but now is on cow's milk. His family bought powdered milk and made that up for him. So his weaning foods were at least 2 and sometimes 3 meals a day. And he ate fruits, typically banana and papaya and garden vegetables sometimes, and some cereals and biscuits he would have. And that's eating 2 or sometimes 3 meals a day. But he rarely ate meat or fish. The family couldn't afford to buy too much meat and fish. So he was mostly eating fruits and vegetables and having 2 or 3 meals a day and drinking a lot of cow's milk. So we've done triage and emergency treatment, taken a history, done an examination, thought about the likely diagnoses, the differential diagnoses. You might want to confirm your diagnosis with some investigations or get a bit closer to your diagnosis with some investigations. So you should think of the investigations that would be valuable. Well, firstly, a full blood examination and a blood film, one would rule out malaria, and 2 might identify the cause of Ratu's anemia. Because he's so pale and because he's got severe respiratory distress, at the same time as you're taking blood for a full blood examination, you take a group and cross-match some blood because of the possibility that Ratu might need a blood transfusion. When you take blood, you'd be taking a malaria. If he came from a malarious area, if that was a possibility, then take blood from a malaria rapid diagnostic test and a thick and thin blood film. You would certainly do a chest X-ray on Ratu, given the severity of his respiratory distress, given the severity of his hypoxemia, and the uncertainty about the diagnosis. Not every child who's got pneumonia needs to have a chest X-ray, far from it. But if they've got a suspicion of an effusion or an empyema or a pneumothorax, you won't really diagnose that accurately unless you get a chest X-ray or you're skilled in ultrasound and you can do that. If a child's got unilateral chest signs on examination, it's important to know that they have whether they've got lobar pneumonia or to rule out that they've got an effusion or an empyema or a pneumothorax. If they've got clinical signs of heart failure, you'd want to know how big their heart was and how bad their pulmonary congestion was. Or if you suspected tuberculosis, you might want to do a chest X-ray that would help you with that. It wouldn't rule in or rule out tuberculosis usually, because the changes of tuberculosis are often similar to the changes of other forms of severe pneumonia. And ideally, you'd get a cardiac echo, an echocardiograph, to look for congenital heart disease in a child who's got those signs of heart failure that Ratu has, but you might not have that available. So we could start with a chest X-ray and go from there. This child's Ratu's full blood examination is here. This was his real full blood examination that had a hemoglobin of 5.9, and you know that the normal hemoglobin is somewhere between 10 and 13 in a child of 11 months of age. So he's got severe anemia. It's less than 6 grams per deciliter. Anything under 7 you'd consider in a child with severe hypoxemia. You'd strongly consider transfusing this child. His white cell count was 30.6, so 30,000 white cells. Again, the upper limit of normal for a child of this age is about 18. So already you know he's got some signs of infection. When looking at the full blood count, you can make more of the white cell count than just more of the signs of infection than just looking at the white cell count. So look at the neutrophil count. His neutrophils are most elevated, aren't they? They're usually somewhere between 1 and 8, and his neutrophil count was 26,000. His lymphocytes were 3.4, so a little bit on the low side. That's not uncommon when you've got a child who's got a severe infection of some sort. Often lymphopenia occurs early on, but doesn't persist. It usually resolves. And the child, Ratu's platelet count was 858. Again, a very high platelet count, the normal being up to 400. And that is an indication of infection. So you've got a number of indications of infection. One sign, so three signs that indicate infection. One is high white cell count. Two is high neutrophil count. Three is high platelet count. And you've got confirmation that he's got severe anemia with a hemoglobin of 5.9. In terms of what could be causing his anemia, then look a bit further and look at that mean cell volume. This is Ratu's mean cell volume. It was 62, again, quite low. And that suggests when the red cells are very small, that suggests that he might have a microcytic anemia. That is a microcytic anemia, and that can be seen in children who've got iron deficiency. And then when you're thinking about these things diagnostically, you need to what we call triangulate information. So you know that he's got anemia, you suspect that he's got iron deficiency, you go back to the nutritional history and you realize that he's drinking a lot of cow's milk, he's not eating much meat, he was weaned early at 3 months of age, he's eating some vegetables and fruits, but not food on a regular basis that's high in iron, and drinking a lot of cow's milk, which can also cause iron deficiency. So you'd suspect from this, you triangulate information, you try to come up with a diagnosis, you'd suspect from this that Ratu might have iron deficiency anemia, and that potentially, well, certainly the cause of his anemia, and it's potentially the cause of even his heart failure. With a hemoglobin that low in the setting of an infection, it's not uncommon to have signs of heart failure. Ratu's RDW, his red cell distribution width, was high, and all that means, you might see that on full blood counts, all that means is that some of the red cells are very small and some of them are a bit larger. There's a variation in size and shape of the red cells, and you see that commonly in children who've got iron deficiency anemia. Their red cell distribution width is high, their MCV, their mean cell volume is low, their hemoglobin is low, and that all points to iron deficiency anemia. And in the setting of a child who's got a dietary history like him, then you've made the diagnosis. This was his full blood count. This is the real full blood count for Ratu, and it shows very pale looking cells. These are hypochromic, which means they don't have much chromatin in them. They're pale looking and they're microcytic. They're much smaller than normal. So they're the full blood parameters. And on his blood film, he had no signs of malarial parasites, and his rapid diagnostic test was normal. So we don't think he's got malaria. He hasn't got malaria as a cause of his fever. He has iron deficiency anemia as a cause of his anemia. But this was Ratu's chest X-ray. It's very hard to interpret because his heart seems so large and his lung fields seem so opaque. Obviously, you should see translucent lung fields, but his lung fields are opaque. And that, again, triangulate information. That goes along well with the fact that he had widespread bilateral crepitations in his lungs. He's got fluid in his lungs. It goes along with the fact that he had tachycardia and a gallop rhythm. He's got signs of heart failure. It goes along with the fact that he has a hemoglobin of 5.9. He's got signs of severe anemia, and that could cause a heart to be this big and have heart failure. And it goes along, you can see how large his liver is, going 4 centimeters below the right costal margin. So when you do an investigation, try to triangulate that information with the history and the examination. And when you triangulate information, when you combine the information, then you are more likely to come up with an accurate diagnosis. So at this point in time, we can summarize everything we've learned from history and examination and laboratory investigations and other investigations. This was a child who had fever. He's got severe respiratory distress, cyanosis, palmar pallor, chest crepitations, grunting and wheeze, tachycardia, 3 heart sounds, and a gallop rhythm. All these things are important. His chest X-ray shows a large heart and bilateral opacities. and his saturations were 77% in room air, and they came up to 93% when he was put on oxygen. That would rule out a couple of conditions, wouldn't it? Cyanotic congenital heart disease is clearly not the cause because his saturation improved when he was put on oxygen. Doesn't mean he doesn't have some form of congenital heart disease underlying it, like a ventricular septal defect, but he wouldn't have, for example, a tetralogy of Fallot, because the saturations wouldn't improve if he had, when he's put on oxygen. He was hypoglycemic, and then when checked again during the examination or after the examination, his blood sugar was 5.5, and he received some intravenous glucose with an IV. This is what happened with him. And his blood film showed severe anemia, neutrophilia, high neutrophil count, and thrombocytosis, a high platelet count. Again, all those things are in keeping with a severe infection. So, but at this stage, we can come up with a diagnosis, I think. And the diagnosis, he has signs of severe pneumonia. He has fever, he has chest crepitations, he's got extensive opacity in both lung fields, severe respiratory distress. Certainly, he has some signs of pneumonia. He also has signs of heart failure. That's very clear, isn't it? That he's got tachycardia, a gallop rhythm, chest crepitations, wheezing, a big liver, a big heart on his chest X-ray, and wet-looking lungs. He's got signs of heart failure. He has severe anemia, and we know that's now iron deficiency anemia. And as I said, a child who's got severe anemia, or to that degree, if they get an intercurrent infection, could go into heart failure. So it's likely that there are three things active here: severe pneumonia, heart failure, and severe anemia. And it's really important to identify all of the underlying causes, because unless they're identified then and treated, then the child won't get better. If all you did was identify this child's severe pneumonia and you treated just with antibiotics, then his heart failure wouldn't get better, his anemia wouldn't get better, etc. So even if you had just identified his severe pneumonia and severe anemia, his heart failure wouldn't get better. So the question is, how do you treat him? And you've got to break it down into each of the three diagnoses you've come up with. Firstly, severe pneumonia. Well, we already know he needs oxygen therapy, and he was commenced on oxygen therapy in triage. You can look up the book on how to do that. He needs antibiotics, and again, you can look up the antibiotics that you should give for a child with severe pneumonia. It's penicillin and gentamicin, or in some circumstances, benzoyl penicillin and gentamicin. If you think that the child might have staphylococcal pneumonia, then it's flucloxacillin or cloxacillin and gentamicin. If you, in certain areas, different antibiotics will be used for different severities of pneumonia, including ceftriaxone, but principally penicillin and gentamicin will cover the major causes of severe pneumonia. That's WHO's standard. Amoxicillin is another possibility. Amoxicillin and gentamicin that's the equivalent of penicillin. Ratu's heart failure, and to begin with, you'd be giving those antibiotics parenterally, wouldn't you? His respiratory distress is so severe that he might not swallow or absorb the antibiotics if you gave them orally. If you can give them intravenously or even intramuscularly, then that will be better to start with than giving him oral amoxicillin, for example. Treatment of Ratu's heart failure is very important. Well, firstly, he needs diuretics and fluid restriction. So very important that we don't give too much fluid to Ratu, because he's already got wet lungs. His heart's already big. So you'd want to restrict him from giving with fluids. You certainly wouldn't want to give him anything like normal maintenance fluid through the intravenous drip. In fact, you'd want to give him virtually no fluid through the intravenous drip, just the minimal amount to keep the drip open and and you'd want to have him on diuretics. With you can look up the book on how to give it. Usually it's furosemide, milligram per kilogram, twice a day, sometimes eight hourly, sometimes 6 hourly if you've got severe heart failure to begin with, and then you stretch it out. For Ratu's anemia, well, you would give a blood transfusion in him because he's got severe hypoxemia, he's got severe respiratory distress, he's got severe anemia with heart failure. That's enough to give him a blood transfusion. But you couldn't just give him a blood transfusion without giving him furosemide. So as well as the furosemide, the diuretics that you'd give him regularly, every 6 hours or every 8 hours, you'd give him an extra dose with the blood transfusion, because he is at great risk of becoming fluid overloaded. The book describes how to manage anemia, severe anemia, how to give a blood transfusion safely. So look up those pages in the second edition, 307 to 308. When Ratu's improved, he should go on to iron, but you wouldn't start iron in the first few days until his infection is well under control. And then, of course, before Ratu is discharged, he'll need some improvement in his diet, that is less cow's milk, more iron-containing foods, and his family will need some support to be able to give him appropriate nutrition that will prevent iron deficiency happening again. So we've done triage, emergency treatment, history and examination, laboratory investigations. We made a diagnosis, thought of the differential diagnosis or the other diagnoses that are present. We've started him on the basic treatment, and now we have to think about supportive care and monitoring. This is very important, especially in a child who's critically ill like Ratu. And as I said, when we looked at the quality of care for children in many countries, we found that this aspect of care was one of the most deficient parts. Children would just receive treatment and not get good monitoring and not get good supportive care, and they would deteriorate often while not being in the right place, like a high dependency unit or a intensive care unit, and without close monitoring and without good supportive care, critically ill children are prone to deteriorating. So supportive care, first of all, Ratu's temperature was 39.7, I think, when he first presented, which is a very high fever, and that will cause anyone's heart to be and lungs to be working over time. So you can bring that, if the temperature is above 38, it's a good idea to bring it down if you can with some paracetamol to try to lower the fever. It doesn't always do that, and you might need to do some cool sponging as well of Ratu. But anything you can do to bring his temperature down a little bit, will reduce his metabolic rate and reduce the stress and the strain on his heart and lungs. Fluid management, as I say, is very important in Ratu to avoid overhydration. He has very severe pneumonia and heart failure and severe anemia. And if he receives too much intravenous therapy and a blood transfusion, then his heart failure will get worse. So very important to not give normal maintenance, nothing like normal maintenance fluid for him. When you start him on some nutrition, then it's all right, because by that stage his heart failure will be better controlled with diuretics and a blood transfusion and treating his heart failure. What type of fluid should you give? Well, I guess ideally he should have minimal intravenous fluid, and he should have some nutrition, and giving some nutrition down the nasogastric tube will, as long as his respiratory distress is resolved a bit. I usually wait for the first 12 hours until you see the respiratory distress settling, after his temperature settles, after he starts on his antibiotics, after his first couple of doses of diuretics kick in, and he'll start to diurese and his lungs will be less wet. and he's had a blood transfusion, then he'll be better after 12 or 24 hours, then to start him on some nutrition. And that should be to start with, probably down the nasogastric tube, or if a baby's breastfeeding, then and their respiratory distress is settled enough, then they can be breastfed again. You should insert a nasogastric tube, which Ratu already had, and give him some feeds. We need to think about what volume of feeds that is safe to give in a child like this. And it depends on the stage of the illness the child's in, how critically their respiratory distress is. You should ideally use a paediatric monitoring and response chart to record Ratu's vital observations and record his oxygen saturation, and so it can be observed in real time. I'll show you what a monitoring response chart is, but you should record his vital signs, his degree of respiratory distress, his oxygen saturation, the AVPU score. These are all critical care observations that you should do on a regular basis, in a child as critically ill as Ratu, every 2 to 3 hours to begin with, and then it can stretch out to sort of 4 to 6 hours as he improves after several days. You can record on the monitoring chart feeding and nutrition. You can record his blood glucose, the treatments that have been given, and the response to those treatments. As I said, the frequency of monitoring should depend on the severity of illness of the child. Hourly if they're in the red zone, I'll show you what that means. 2 hourly if they're in the orange zone, and they need to be checked by a doctor at least 3 times a day, often even more if they're critically unwell. So checked by nursing staff regularly, every hour or every 2 or 3 hours, and checked by a doctor at least 3 times a day. But for some children that are this sick, I would be at their bedside for several hours, just waiting, adjusting therapy and making sure that they're responding to the treatment that they're being given. And then you can check them a bit less, 3 times a day, but at least that. This is a monitoring response chart, and you can see that on the top line there's the date and the time, and you can decide the frequency of observations. You decide whether it's hourly or 2 hourly or 3 hourly or 4 hourly or 6 hourly, and you can then put in appropriate times. You can put in appropriate times. You can record the temperature, and the monitoring response chart is divided into, it's color coded, and it's divided into 3 different colors. One is amber color, one is red color, and one is white. And the white areas of the chart are generally within the normal range for a child. The amber areas are getting into a zone where it's a bit dangerous. This is not normal. It's outside the normal range. And the red areas are in the critical zone where those observations would be critical, and there needs to be a response to that. So if a doctor or a nurse record observations that are in the amber zone, the child needs more frequent observations. They may need some adjustment of therapy. If the child has observations that are in the red zone, then they certainly need more consideration of what's going on. Why are they deteriorating? Why is their observations reached the red zone? What can we do about it? What has the child got an underlying condition that we haven't identified? Have they got a comorbidity or something that we didn't identify? Have they had some complication or deterioration? You need to think about all those things if a child is in the red zone. This was Ratu's observations, and what you can see is that he started off, some of his observations were in the red zone, some were in the amber zone, a few were in the white zone, so they were okay, like his capillary refill, but certainly his respiratory rate, remember it was 70 when he first presented, and you can see over the first 6 or 8 hours his respiratory rate comes down, and that's with antibiotics lowering his fever, giving him diuretics, giving him a blood transfusion. His respiratory rate gradually normalized. So that's moving in a favorable direction. His oxygen saturation, which was quite low to begin with, wasn't it? 77, I think, when he first presented, so in the red zone. It then went up as he was given oxygen into 93, I think we saw, and then it stabilized within the 90s. So again, moving in a favorable direction that you can see over the first 4 to 6 hours, this child is improving. His degree of respiratory distress was severe to begin with, you saw that, and then it moved to the moderate zone, and then within 12 hours had become only mild respiratory distress. Again, after the therapy, blood transfusion, oxygen, antibiotics to lower his fever, etc., diuretics to make his lungs less wet. And his heart rate also, which was very high to begin with, 180, came down within to the normal zone. His blood pressure was able to be recorded, and that stayed within the normal zone for most of that time. And his blood sugar, as you recall, was 1.8 and became 4.5 or 5.5 soon after he was given glucose. You can record the changes that are put in here. So his oxygen, intravenous glucose, antibiotics, etc., that you've given. So using a chart like this can help you assess that the child's making some improvements, but it can also tell you if a child deteriorates, and you can stretch out the frequency of observations as a child's improving. It to begin with, it was probably every hour, and then it can be extended out to 2-hourly, 4-hourly, etc., 6-hourly observations as the child stabilizes and when they become more very much a ward-based patient rather than a high dependency level patient. Now, so we've talked about triage and emergency treatment and taking a history, doing a thorough examination, coming up with a diagnosis or a differential diagnosis, doing laboratory investigations, finalizing your diagnosis, giving treatment for the underlying and the diagnosis and any comorbidities, reassessment and supportive care and monitoring. Part of monitoring is reassessment all the time as to whether or not the child's responding to the therapy you're giving. And then then comes discharge planning and follow-up. And now, in any child who presents, you should think to yourself, well, what do they need to achieve before they can go home? And you should try to explain to the parents what milestones, if you like, the child needs to reach before being safe to go home. You shouldn't think about discharge planning only on the day that they go home. You should think about it the day after they're admitted and think, well, what does this child have to do before he or she can get home? And then you should think to yourself during the admission, what follow-up does this child need? Almost all children need some sort of follow-up, whether it's nutritional follow-up, whether it's follow-up for complications of their disease, whether it's lots of different reasons for follow-up. We'll go through this with Ratu. Well, before Ratu's discharge, you might think to yourself, well, first of all, his respiratory distress needs to resolve, because that was why he came in the first place. He had severe respiratory distress. You would want that to be resolved. His hypoxemia was very severe when he came in. You'd want that to be resolved. So he can't go home until his oxygen saturation is more than 90% on room air, and consistently so. He can't go home while he's still got even moderate respiratory distress. Maybe with mild respiratory distress, he could go home, but largely those things have to resolve. He can't go home until he's completed a course of parenteral antibiotics. It doesn't mean he needs 10 days of antibiotics or even 7 days of parenteral antibiotics, but he needs a course of antibiotics, maybe 5 days of parenteral antibiotics followed by another 5 days of oral antibiotics would be sufficient for most infections. He can't go home until he's able to take oral medications, because he might need ongoing furosemide or he might need ongoing oral antibiotics, and he has to be well enough and his family have to understand how to give oral medications. In this case, in Ratu's case, you'd want to check his hemoglobin to show that there's been an improvement in his hemoglobin, not after the blood transfusion. He needs to be started on iron. And as I said, you can't do that in the first few days. You have to wait until his infection is under control. The reason for that, you may know, but you shouldn't give to an acutely infected child with a high fever, it's not a good idea to give iron, because sometimes for some infections, they can be made worse not all infections, but some infections can be made worse by the administration of iron. So I usually wait until after they've had a few days or 5 days of treatment, their fever's resolved, their infection's under control, then you can start them on iron. And you need to explain to the family that he'll need to take iron for at least a month and usually 2 months. And of course, they need nutritional follow-up to change their diet. And you can't send this child home until his parents understand the problems, until they understand what the underlying diagnosis was, the things that led up to him becoming so unwell, and how to look after him in the future. And ideally, because of Ratu's presentation with heart failure, you'd want to do a cardiac echo just to rule out the fact, even though we think he's got heart failure related to anemia. In fact, Ratu he didn't have a ventricular septal defect or any other congenital heart disease. He just had severe anemia and severe pneumonia. But you'd want to ideally rule out a ventricular septal defect or some other congenital heart disease that might have exacerbated, might have been the underlying cause of his heart failure. And if you can't do an echo in your hospital, then referring Ratu on when he's more stable to have an echo done by a paediatrician or a cardiologist would be a good thing to do. What follow-up does Ratu need? Well, certainly he needs follow-up for his anemia, and he needs follow-up to assess his nutrition, because his nutritional intake wasn't very good, was it? It wasn't a balanced diet, and he needs more of a balanced diet in the future so he can grow. His growth wasn't too bad. He was within the 2 standard deviations of the mean, but even though he was having enough calories, he wasn't having the right nutrients, certainly not having the right amount of iron. So this has been a long case to go through, but I wanted to describe to you how you can use the book and use the stages of management to manage any critically ill patient. So just in summary, Ratu and many children present with one symptom, cough and fever or respiratory distress, but they may have multiple problems. And so Ratu had severe respiratory distress, and that was due to pneumonia. He had an acute pneumonia, acute infection. He also had anemia, which he didn't just have for 5 days. This had been a relatively long-standing thing related to his poor nutrition, wasn't it? Relating to the amount of cow's milk he drank and his poor diet since being weaned. And so he had anemia due to iron deficiency, and we were able to, again, using the triangulation of evidence, the history, the examination, the laboratory investigations, we were able to come up with a diagnosis of that just using very simple tests and using clinical skills, nothing very complicated. He had heart failure due to the anemia, and he had severe pneumonia. And so, and heart failure due to the severe pneumonia. Remember I said if a child's got underlying anemia, if they get a severe infection, then they're quite likely to have signs that will exacerbate their heart failure and actually will cause their hemoglobin to drop even further, usually with an acute infection. An emergency treatment that you saw can be given very simply. Giving a relatively small amount of oxygen by nasal prongs can bring a child's saturations up from 48% to 98% or 49% to 98%. And it just showed you how giving a small amount of treatment can actually make a big difference. And with Ratu, all the treatment he needed were relatively straightforward and relatively simple and can be done at a district level hospital or a first level referral hospital. But you need to identify each problem before and treat each problem if the child is going to survive and do well. If, as I said, if Ratu had only had his pneumonia treated, then he probably wouldn't have done so well. And monitoring and supportive care is vital because it's really important that we detect the deteriorating patient and to be able to monitor how a child is improving over time. And don't forget early discharge planning not discharging early, but early discharge planning, and try to explain to the child's family what the child needs to do to be before the child's discharged. And don't forget follow-up. Every child needs some sort of follow-up, whether it's for their Ratu would also need to have his vaccines before he went home, of course, wouldn't he? So all of this is contained in the pocketbook of hospital care for children. This was just going through one module of the teaching materials based on this book. And I'm just going to stop sharing my screen and just finish off now. Just one of the modules we went through today, and there'll be other series of lectures that go through the other modules, but I just wanted to give that as an introduction to the book and a module about the book. So thank you for your time, and I hope that's been useful. And I hope that you'll get a copy of the Pocketbook of Hospital Care for Children and use it in your everyday clinical practice. There'll be more of these teaching modules that I'll give short lectures for in the coming period of time, and they'll be on the same YouTube channel. So thanks for your time, and look after your patients. Thanks, everyone.